Okay, my name's Infante. I'm an occupational therapist here at Occupational Orthopedic Surgery Group. I've been practicing for the last 3 years, which is also how long I've been here. I originally started out in the work hardening program, which is it's more of a total body rehabilitative process as opposed to this where I work now, which is just a specialty hand clinic.
What is your role in the clinic?
Typically my role in this clinic consists of just standard patient care, and by that I mean developing and implementing structured and purposeful programs that are specifically tailored to each patient's needs. I also delegate tasks to my staff, and really that's pretty much it. Oh, I document everything that I do throughout the day.
How do you typically evaluate a patient?
Well, my typical evaluation usually begins with me getting a really good background on the injury in question. I get the patient fills out a previous history, medical history questionnaire, talk about their previous surgical histories, and we talk more or less about the date of the injury and also more or less how the injury occurred. This is usually followed up by an assessment of their active range of motion, or just more or less how they're moving. Usually when the patient comes in, I try to get a quick overview of how they're walking, their gait more or less, their posture, and what it is that they're guarding. Generally I use a goniometer to measure out their deficits. It's just kind of a little numbered scale more or less that I use. It's for elbows and wrists, for larger joints such as shoulders, and then we have the smaller finger gonies. So after I assess their active range of motion, I move on to their strength. I usually try to start a joint above and a joint below the injured joint. So if it's a wrist, I'll start at the elbow and I'll check the elbow strength just with manual resistance. I'll get a point where I hold them at, and I'll actually physically gauge how strong they are, usually on a scale from 1 to 5. After that, I check their grip strength with a dyno, and you can kind of see it just more or less gauges their overall grip strength. With that one, we also check their pinch and their 2-point pinch and their 3-point pinch, and sometimes we'll check their lateral pinch as well. Moving on from the strength assessment, I go ahead and assess their pain. Generally, I just ask them what the pain is on a scale from 1 to 10 and try to decide more or less what I'm going to do from there. I also do like to go over sensation. I'll check their light touch and also their 2-point discrimination. We usually use just the 2-point discrimination tool. We have 1 point, we have 2 points, and I'll usually poke the ends of their fingers just to try to try to figure out how well those fingers are innervated. Generally, that gives me an idea of how well they can manipulate objects in their hands. The light touch, I'll use a Sins-Weinstein monofilament test, which is more or less just fishing line, different grades of fishing line. They have a really fine fishing line, all the way to a much heavier gauged fishing line. And this more or less, tells me whether or not they have any innervation in their fingers. They feel any light touch. Generally, if they can't feel this heavy set line, then there's a big issue.
How do you come up with the treatment plans for individual patients?
Generally, I take the information that I get from the assessment and I try to apply it to really just my own treatment format. There's a lot of protocols you can follow for each individual diagnosis, but generally I try to work on the patient's pain first, and then I move on to their active range of motion, and once we've gotten most of that, then we move on to the strengthening phase. I try not to work in any other order. That's generally what works best for me. But generally, I try to just get the patient motivated to do what they need to do. I only get them for 1 hour a day, and the other 23 hours is really up to them. So, what I do is really a small part of the total process.
What equipment is used to treat patients?
Generally, we use modalities. And by modalities, I mean we use hot packs, cold packs. We use electrical stim. We have several types of electrical stim. We have a neuromuscular stim, which actually it stimulates not just the nerve but the muscle, and it stimulates it to contract. We have IFC or interferential, and that's usually used for pain and swelling. We also have HVG, which is a little bit of a stronger electrical current, which also addresses pain and swelling. Look at this. We use a hot pack, and it's really more of a moist heat. We usually enclose those in these wraps, and really just try to get the patient moving first off before anything else. We get them heated up before we get them moving. Okay, also some of the other devices or toys, as we call them. We have several other that are specifically used, for whatever it is that we're using them for. Wrist extension, pro soup movement, wrist extension, also strengthening. Some of my favorites, I like to use the flex bar for forearm strengthening, wrist strengthening, digit strengthening. We also use it for desensitization over the scar tissue. The kind of the rough band kind of helps with that. I mean, we have specific tools specifically for desensitization too. They're in there. Pretty much anything you can think of to twist or squeeze or pinch, we pretty much use.
What has been your greatest obstacle so far in this profession?
Greatest obstacle? I'd have to say it's budget. Honestly, I think I could do a lot more if I had more budget. Obviously, I guess that's true with anybody. But I mean, the true heart of OT really resides with purposeful activities. I mean, when we talk about activities, it could be anything. It could be playing video games. It could be making pottery. It could be planting things. Here, we're kind of limited to the same tools, and really just limited to what we have in front of us. There's not a lot that we can use as far as OT wise. And that's kind of the whole philosophy of OT is, you get people moving and doing things again by sparking their interest, and they kind of do the rest of the work. So when we talk about patient flow, when we talk about that time that you spend getting better, it's going to be something that you're going to want to do.
What is your greatest success or favorite story so far in this job?
My greatest success, really anytime we get a patient back, it's successful. But I guess to go off that, I guess the story that sticks in my mind the most is of a young gentleman who was in a motorcycle accident, and he ended up losing both arms and both legs. He really had just a very good outlook on life. Wasn't at all mad or as far as I could tell, too distraught about his situation. He was very grateful, very grateful about what he was able to get back. He last time I saw him, he was getting fitted for his prosthetic legs, which he was extremely excited about because he was a decorated runner. But I mean, there's so many different patients that are just that have come from very difficult and trying times. But yeah, that one would probably be the most memorable.
What other positions or job do you currently work at, and what type of work do you perform?
I'm also working at UMC, or University Medical Center, or it used to be known as Thomason. It's the only level 1 trauma center in within 500 miles of El Paso. Um, Generally, there I work in acute care. I'm only doing inpatient rehab, so I mainly get all of the motorcycle accidents, motor vehicle accidents, shootings, stabbings, a lot of wound care. I'd say I spend about half of my day there just doing wound care. The other half is probably spent with CVAs or stroke patients doing some kind of activities, purposeful activities. We get them transferring to the restroom. We get them dressing. We get them eating normally. We get them brushing their teeth. Anything that is really an activity, like a daily activity. Um, Other than that, that's pretty much all I do there.
What is the difference between OT and PT?
Well, besides the fact that OT primarily deals with the upper extremity and PT deals with the lowers. OT, we kind of treat patients holistically. We don't just treat the physical deficits. We also address the psychosocial and cognitive deficits that patients have. Um, Generally speaking, I mean, OT and PT are pretty similar, other than the fact that they don't touch hands and we don't touch feet.
What are the various types of occupational therapists?
Besides myself, which is a hand specialist or outpatient, I work in an outpatient clinic. You could also work in an inpatient or acute care. You can work in pediatrics. You can work in senior nursing facilities. There's a whole plethora of places you can work at, but generally there's inpatient, outpatient, pediatrics, geriatrics, and there's occupational therapy managers as well. So those would be, I guess, the general various types.